So just like any other, you okay holding it in that position? Yeah. Just like any other, like looking at the ankle, looking at a wrist, looking at an elbow, you're going to develop, the more and more you do this, you're going to develop your own kind of protocol. So I have my own protocol, how I do it. It'll become more efficient if you do it the same way every time. So I always start with the anterior knee. Again, you want them at about 20 to 30 degrees of flexion, just like that. And the first thing, if this comes up, am I on the wrong probe up?
Oh, yeah, you might be. See, we can switch it.
Yeah, let's switch it to.
There's two linears on there. I'm not sure which one.
Yeah, this should be good.
Does it say, like MSK?
Yeah, general. Okay. All right. Okay, so what we want to do is we want to start over that quad tendon and that suprapatellar recess, okay? So what we're looking at here is this top, obviously the skin, subcutaneous tissue, and then this structure here is your quadriceps tendon, okay? So what I was saying earlier is we want to scan far laterally and far medially on that to get the whole width of the tendon. It's a little wider than you probably think it is, so when we go in short axis, you can see just how wide that tendon is. So it comes all the way here, all the way over here. And so I like to check this in both planes. Going back to that suprapatellar recess, okay, so you have suprapatellar fat pad. This is a normal structure. This is the prefemoral fat pad, again, normal structure. This down here is your femur, and then up here is the patella. Now, if I straightened her out, you see how this looks dark now, and you're like, oh God, they have horrible quadriceps tendinopathy. Thus the reason we want to put them in flexion, and then once you do that, you can see that it becomes normal again, okay? So just know that. What you're looking at right here, this little dark area here, that's a little joint effusion she has. And so that would be your target for any intra-articular injections if you want to straighten out. And you can make that pop a little bit too. So flex your quad, Lori. So she doesn't have much of an effusion in there, but what we're talking about is this right here between the fat pads, this right here line going in there. So that's going to be your suprapatellar pouch. Again, a target for intra-articular knee injections. Okay, so continuing on down that quad tendon, you're going to see the bone of the patella. And then what I wanted to show you, and I kind of mentioned in the talk, so you see these fibers here of the quad tendon. Let's go a little less deep. But you can see this little thin line of connective tissue that this is all connected. And then right here, you probably don't think of it, but that's actually the beginning of your patellar tendon. So it kind of originates up high on the patella itself. So this is all patellar tendon here. Again, let's go a little. What you're going to have is a little thickening here. Do you have pain in this?
Yeah.
Yeah. So you can see here that, I'm going to try to flatten that out. Yeah, she's got a little, and this is a common place you're going to see proximal patellar tendinopathy. Almost all the patellar tendinopathy is going to be proximal. See this little dark area in here? I think she's probably got a little insertional tendinosis going on there. And you can see she's got a little cortical irregularity deep to that. So I think if she had pain there, she's got pain there. So she's got a little proximal patellar tendinosis there. So it's kind of a cool little bonus for it. Not for you, but
add it to my list.
Yeah, nice bonus. But you can see here, this is normally thicker there, and if we go distally, you can see this broad attachment. It's usually darker in appearance too, generally, so that's why I was a little reticent to to call this an injury, but she's got a little erosion or osteophyte there, but I think that's real. I think she's got proximal patellar tendinosis. Keep in mind that that patellar tendon should be, again, relatively uniform thickness throughout. I'm losing my gel. And she does, with the exception right here. This is an interesting finding. Okay, so why I have them in this position, I hyperflex her, if you're okay with me doing that, now that I know what's going on. So this is how we look at the trochlear cartilage. So really what you do is you take your probe, put it right on the patella, and then just come to the superior aspect of the patella, and you drop down that little divot, and there's your trochlear cartilage. So I follow this laterally. It's hard to see the whole thing just because of the contour of the knee. So what I'll do is I'll press that lateral aspect of the probe down, look at the lateral trochlea, and then scan all the way medial. She's got a little bit of thinning of it, not too bad. A little more medial than lateral, I would say. Okay, so that's your trochlear cartilage there. So pretty easy to see, guys. So again, hyperflex, drop right above that kneecap or patella, and then angle that probe down, and you go from medial to lateral or lateral to medial. Okay, so that's that. Next, let's go ahead and look at the medial aspect of the knee. So remember the position we want her in, and for this, so we want her to externally rotate at the hip or lay on our side, which is what I do too, and then have her again flex that knee slightly about 20-30 degrees. The first thing I look for is that proximal attachment of the MCL. And so that's what we're looking at here, guys. Now, this normally will look a little darker at the attachment sites again, a little bit thicker there. As we get into the kind of the meat, if you will, of the MCL, it's gonna become less. It's gonna become more It's gonna become more echoic. But a little bit of thickening here can be normal. But what you're looking for are little rents, little tears, little. I'll talk to you a little bit more tomorrow about some of the things you want to look for. But that's the MCL. And you want to follow that down, and as you follow that down inferiorly, you're going to run into the joint, okay? So we're looking at the medial joint space, okay? So again, femur, tibia, and then this little, looks like a Trivial Pursuit piece, is that medial meniscus. You can scan anteriorly on that medial meniscus, and it goes way up anterior, so make sure you do that. And then you can scan posteriorly. Again, you got to fight anisotropy. And so you can see that pop in there, and that looks pretty good. Again, if she had meniscal extrusion, we would see probably some fluid in these little gutters here from the tears of those meniscofemoral and meniscotibial ligaments. She doesn't have it, so that looks pretty good. There's an attachment site here, but then that will continue down and reattach about 6 to 7 centimeters beyond the joint. As we scan further, now we're in the pes sanserinus. So here's your pes sanserine tendon, so sartorius, gracilis, semi-T. If I put on the Doppler, I think you're seeing the genicular arteries there. So that's kind of how I evaluate the pes sanserinus region. If I see thickening of these tendons in short axis, or it's really hypoechoic, then I'm thinking that there's going to be some tendinosis there. Then I will scan it more completely. But just for time's sake, I just wanted to let you know where that is. So it's this kind of flat, broad area of the medial tibia. Okay. What else on the medial aspect of the knee? That's really the main things I wanted to show you there. So let's move to the lateral aspect of the knee. You want to wipe there? Thank you. And we want her again flexed about 20, 30 degrees. A little more gel. Okay, so the first thing that I find on the lateral aspect of the knee is big structure, superficial structure here. And that's your iliotibial band. So we're talking about this thing that looks like a river going across here. So that's going to be your landmark for the lateral knee. You're going to see it come down, and that goes all the way up your leg. Here's where it comes above the femur. If you get tendinosis there or friction, this is kind of that friction point, iliotibial band friction syndrome. You can see she's got a little subcortical irregularities going on there. And then you can follow it all the way down past the joint and to this attachment here, attachment site at Gertie's tubercle. Again, just like the other places I was showing you, having it thicker in that area and a broad attachment, it's going to appear darker and thicker. Do not call that pathology. That's what it normally looks like. Okay, so while we're here, what we're going to do is we're going to drop a little posterior, and can anybody tell me what this is here? That's the popliteus tendon, so that's that little popliteal groove. What I do is I scan this looking for any fluid around the popliteus. Typically, if I'm going to see a tendinosis there, there's usually fluid around there. This looks like she might have a little splittish tears in there going on there. Does that bother you over here? Yeah. Yep. So I think she's got a little tendinosis of the popliteus tendon. Okay, so I'm here. I'm going to rotate that probe, the inferior aspect of that probe posteriorly, and catch that LCL. And you can see that LCL. I can't really point it out, but can you guys see that LCL? It's deep to the, so popliteus, LCL. And you can see it attach right there below the arrow. You see that fibular structure attaching at the fibular head. So that's the LCL. So again, you find that popliteus tendon, rotate the inferior aspect of your probe posteriorly, and then you look for that fibular structure. Don't see a ton of LCL, at least in my practice, I don't see a ton of LCL pathology. So I don't always look at the LCL, but while you're there, what you're going to do is you're going to look at that lateral joint line, and you're going to look at, again, and she's got a little something here too. Yeah. So again, femur, tibia, joint space, lateral joint space. What I was noticing with her is you see how this superior aspect of the meniscus is not really flush here. It's kind of extruded. And then you see this hypoechoic region right here. I think she's got a lateral meniscofemoral ligamentous injury there. So that meniscus I would call mildly extruded. Now, looking at that meniscus, I'm not seeing anything that looks like a tear. We'll go over tomorrow on the pathology what that would look like, but looks pretty good. Okay, so that's the lateral aspect of the knee. Again, you can come down and look at the fibular head. I'm not going to get too much into it, but you can look at the proximal tib-fib joint that I was telling you about right there, and those different views, coronal anterior oblique. Where is it? There it is. There's our proximal, so that's the fibular head, and then that little invagination right where that arrow is that joint. Don't inject that a lot, but just having knowledge that you can inject that, it's a tiny little space, can be helpful for you. Okay, what else? Okay, let's have you on your belly. I'm just going to switch knees on this one. What I typically will look at, main structures I'll look at in the back of the knee. I'm not going to get too much into neurovascular structures right now, but what I'm going to look at is the posterior horn of the medial meniscus. Now, you're going to have to drop your depth a little bit here in order to see this. So what you're looking for is I look for that edge of the femur. Again, you can see hyaline cartilage on the posterior aspect of the femur. That by the way, is non-articulating, so that's not a weight-bearing cartilage right there. And then you want to look, where's my focus? There we go. And then you want to intonate that probe. Ooh. Turn the gain up a little bit. Which one's the gain on this? Do you know?
2D.
2D, thank you. Sometimes you got to turn the gain up to see this really well. But you can probably hallucinate it better. Turn, there we go. Okay, so what we're looking at there is, so the left is the femur, that bone to the right is the tibia, and then in between there you can kind of detect that posterior horn of the medial meniscus. Doesn't look really great. Do you have an issue with your meniscus?
This is my bad one.
Yeah. Yeah, so I think, so you see that anechoic cleft? You see that anechoic cleft through there? So it looks a little blunted, like she had it shaved, so it may be post-surgical changes. But it's really kind of hard to make out our posterior horn of the medial meniscus here. So that's why I asked if she had an injury or some sort of surgery. Okay, so she doesn't have much of meniscus. That's why it was kind of hard. That's why it's kind of hard to see. And then this is where you're going to find the Baker cyst if she had one. So you want to look at the semimembranosus tendon as it comes across here. See it coming down here. And then where the gastrocnemius, where they kind of crisscross, this is where you would look. And I think I can hallucinate a little cyst right here, but she doesn't have a big one. So it looks pretty good for the most part. So where you see these crisscrossing right here, that's where you want to look for your Baker cyst. So when you scan tomorrow, make sure you look for that area, because I guarantee you one or more of those models will have one. So that's Baker cyst. Again, you can come over to the lateral knee, do the same thing. Look at the lateral meniscus. A little dark here on her. Let's turn up the gain. So there's a better view of that lateral meniscus. So right in here. She's got a little something here, it looks like, as well. So posterior horn of the medial and lateral meniscus. Did you have lateral meniscus surgery as well?
No.
No? Okay.
It's just, I don't have an ACL.
Might have that in your future. So lateral meniscus there. What else? Let's flex you just a little bit. I'm going to put this towel underneath here. Okay. All right. And so the last thing I wanted to show you guys, so this structure right here, so you learn by now, honeycomb structure, what is it? It's a nerve, right? So what nerve would that be? That's your sciatic nerve, right? So as we come down, let's turn the gain down now that we can see that a little bit better. Let's get the focus up here. So the sciatic nerve is going to come down, and right here, a little hard to see, I'm not on a nerve setting, but can you see the split right there, guys? I'll go back. So sciatic nerve, center of your screen, split. Here comes your perineal nerve that's going out laterally, and you can follow that all the way down. You just keep following it, and then here it comes, it's going to come down around that fibular head, and it's going to pop over that fibular head eventually right there, and then it's going to continue down the anterior lateral leg, and then the tibial nerve. So when you look at this, you see that split, there's the split, again the split, that perineal nerve is going to go off in its own direction. The one that stays kind of in the middle is going to be that tibial nerve, and that's going to go down the back of the knee and then eventually go medially. So when you see the split, just realize that the tibial nerve is the larger of the two, and that perineal nerve just takes off. It's off into the sunset there. Something else you can see deep to everything is the popliteal artery and vein. So things for like DVTs, I don't do that work. I'm pushing really hard on here, so you don't really see the vein too much. You can see the artery right down here. So the nerves are going to be superficial to those structures, but it's kind of in the same neurovascular bundle region. And then down the back of the knee, you see it split. And is there anything else you wanted to see? No? Okay. Let's see, what else? Oh, here's something else you can look at here. Almost done, guys. Sometimes it's difficult. Do you have a PCL? I'm going to try to show you some of the PCL, but let's see if our model is cooperating here with our structures we need. So the PCL, yeah, she's got a wavy PCL. So really kind of difficult to see, but this right here is your PCL. And usually you can see a little bit more of it, but it's usually going to be sharper. It's going to go like a 45-degree angle. See how hers is kind of wavy, and you can't really make it out that well. So, yeah, I think that's probably a chronic injury of the PCL there. So, again, if you suspect a PCL injury or instability, get an MRI. Don't rely on this. Although ultrasound's great for a lot of things, so I don't really do. That's about it, guys. Thank you so much.